My front plan is healthcare reform. How many have heard of healthcare reform and Affordable Care Act? Do you understand it? Okay. You know, when we do presentations a lot, we do a disclosure statement. My disclosure is I don't sell any products. I'm not here to, you know, to push any certain things that I talk about. And the information I'm giving you is evidence-based to the best of what's in the literature. Now, here's the real disclaimer. With the Affordable Care Act, much of it is speculation. So I'll tell you what we do know, but there's a lot about it that we don't know. All right, we're ready to go. President Obama signing the Affordable Care Act into law. This is Kathleen Sebelius. She's the Secretary of Health and Human Services. In her address in 2011, here's what she said about the ACA. She said that this is going to help you as Americans because it'll make sure more Americans have health coverage. Well, what did she mean by that? Well, for one thing, on dependent coverage, it changes from age 24 to 26, and that puts 2.5 million more people with health care coverage. It changes how insurance works so that there's things called insurance exchanges. And that means that small businesses will have equal opportunity to get insurance for their employers as large companies. It also means that as individuals, you may be eligible for a rebate on your insurance. So the push here is really to get people with health care coverage. It did, in the original ACA Act, increase the eligibility for Medicaid up to 133% of the poverty level, which would have added 15 million more people that would be insured, about a 30% increase in Medicaid. We'll go back to that because the Supreme Court had other things to say about that. Shedding light on insurance companies. Well, with the ACA, an insurance company cannot raise your rates over a certain amount without putting it in writing and explaining why they're changing rates and getting permission to change rates. So your rates are going to be held and not artificially increased. But there's another thing that will help even more than that on insurance control. And it's this one. The 80-20 rule it's really more technically called the medical loss ratio. And medical loss ratio means that of your premium dollars that you're spending on health care, so your health care premiums, the insurance company now has to spend 80% of that on actual health care. And the 20% is for profit and administrative expenses. So what does this mean? It means that, and when did this actually happen? It happened in June 1st of 2012. All the insurance companies had to give their 2011 reports in of what they collected in premiums and what they spent on health care. And the result was that in Florida, Blue Cross Blue Shield had to pay back $25 million because they were over the 80-20 cap. United Healthcare had to pay back $23 million because they were over the 80-20 cap. This is just in one state. This is in Florida. Those are the highest paybacks of any state, but that's just one state. So it was about $1.1 billion that has to be returned to the beneficiaries. What this means is there will be price controls because there's no value for an insurance company to charge more than what they're going to actually spend for their beneficiaries because they have to rebate that to you anyway. Interestingly enough, in both cases, it was small cap. It was the small providers, small businesses that got the money back. And it just shows that the small businesses are the ones that had the harder time really negotiating good rates for their beneficiaries. The big corporations were able to negotiate better rates. But now it puts everybody on an equal playing field, whether they're an individual or whether they're a small company or whether they're a large corporation. And if you can't afford insurance, there will be tax rebates, so that will help you be able to get insurance. Expanding access to free preventative care and services. This is both in the private market and in Medicare and Medicaid. This has to do with a free wellness check, which should be part of your insurance either this year or in the coming years. Colonoscopies, mammograms, flu vaccines, all these things are now in the preventative care with no charge. Strengthening Medicare, they're really going after the Part B services to try and decrease the deductible and the copays for Part B. And they're also trying to go after the donut hole to try and decrease the donut hole. This year, there will be a $250 rebate to help people pay for the coverage they have when they hit that donut hole. Does everyone know what the donut hole is? On Medicare D, when you're on Medicare, they pay for your drugs, but at a certain point that's capped, and then there's a no coverage, and then as the dollars pick up again, there's coverage again. So that's the donut hole, that period where there is no coverage, and then your expenses for medications go way up. By 2015, they'll eliminate the donut hole. Putting more doctors in the community, there's about 10,000 medical professionals in the National Medical Corps to help serve underserved areas of the country. And finally, improving patient safety. And this has actually been going on for quite a while now. But there's two main categories of patient safety that all these organizations are interested in. And those are preventing readmissions to hospitals, number one, and preventing hospital-acquired conditions, which is the nice name for medical errors. According to the Institute of Health Improvement, there's about 100,000 deaths from medical errors every year. CMS has partners in patients, Joint Commission, the IHI, the National Institute of Health, the Association for Research and Quality, all organizations looking at patient safety. So those two things, readmissions and preventing hospital-acquired conditions. Since 2008, hospital-acquired conditions have not been reimbursed by Medicare and Medicaid. And those might be a fall that happens in the hospital, a pressure ulcer, an infection of many different kinds. In surgery, if they leave something in and they have to go back and get it, that's not covered. So the payers are starting to say these are mistakes that should never happen. As patients, you got to believe these are mistakes that never should have happened. So there's money in there, about $1.7 billion, to protect patient safety. Cracking down on healthcare fraud, that's another $1.9 billion to help crack down on healthcare fraud. Now, I work at Madonna Rehab Hospital. I run the nursing home over there. I've made mistakes, you know, in billing and how we do things, and those mistakes are considered fraud. So a lot of what's seen as fraud out there is mistakes. A lot of it is fraud. I mean, there are people that do commit fraud. So there's a lot of money in there to try and decrease waste. So in some states, maybe like Nebraska, governors are waiting, you know, before they get into healthcare exchanges and really get into healthcare reform, because they're waiting to see whether the laws could actually stay or not. Maybe the election will change things. Well, it's not going to change things. What's already happened is, and tell me if these are good things or not, pre-existing conditions for people under age 19, that's already here. Dependent coverage, we already talked about there. It increases from age 24 to 26. Lifetime maximum is eliminated. So if you have a chronic condition, you're going to hit that lifetime maximum. That's eliminated now. And employers must provide a summary of benefit notice, an SBC. What that is it's a uniform explanation of what your benefits are, what's covered, what's not covered, and what your obligations are as far as payment. It can only be 4 pages long, and it has to cover specific areas. And by the end of this year, you should start receiving that if you have commercial coverage. And we talked about the MLR, the medical loss ratio rebates. Those are big money. This year, hopefully they won't be. It'll depress how rates get escalated. And so far what I'm seeing in the ACA is insurance reform to protect consumers and to try to get more insurance for more people so that there's better coverage, so that we all have coverage for primary care and hospital care. The timeline is, here's how it's going to roll out. By 2013, all of us will have to spend more money on out-of-pocket in order to deduct it on our Part A on our income tax. So right now, if your medical expenses are more than 7.5%, anything over that you can write off as an itemized deduction. Beginning 2013, it goes up to 10%. So more of your own money out of pocket is what you're going to have to pay. So how do we pay for the ACA? There's little hidden taxes in all of this. And some of the hidden taxes aren't part of the ACA. Unfortunately, it's a part of the ACA that isn't going to move forward. 2014, everybody's going to have insurance, either commercial insurance that they purchase themselves that they get through their company, or a government insurance like Medicare, or a government, or like Medicaid, which is not insurance, it's actually a type of welfare. The penalties right now are very low. We'll see what happens with those penalties for people that don't get insurance. Right now, the penalty that you pay may be less than the cost of your premium. So you could pay a penalty and get nothing, or you could pay a premium and get some insurance coverage. So it's still a consumer choice. 2015, we're going to start to tax what they call the Cadillac plans. Part of the insurance exchange means that a plan has to cover these basic things. So if you're going to sell insurance and have a health care plan, it has to have minimum of coverage, and there's 3 different tiers for how that coverage is going to work. Well, the Cadillac tiers, and that's a lot of money for insurance, but the Cadillac tiers are going to be taxed, and 40% is a pretty hefty tax. By 2020, that's when the gap, the donut hole, will go away. So that seems a long time, but sooner or later, 20 or 20 will be here. And that gap will go away, because that's a hardship. It's interesting that the average number of prescriptions per American, per person, is how much do you think that would be? How many prescriptions do you think we have on average? Between 25 and 65, you know, what I call young adults, okay? Under 65. It's 12. And for an elder over 65, it's 38. So that's a lot of prescriptions. So a lot of the elders that are on Medicare, that's a lot of money that they're paying, whether they're in generics or not. So and June 28th, 2012 is when the Supreme Court ruled on whether the ACA was constitutional or not. And in a 5-4 decision, they said, yeah, this is constitutional, except for one part. And that's the increase in Medicaid beneficiaries, increasing the eligibility to 133% of the poverty level. That would have added 15 more million people to the ranks. And they said that that's not constitutional because Medicaid is a 60-40 split. The feds pay 60%, the state pays 40%. And what the Supreme Court said was it's a state's right to determine how to spend state dollars. So they can opt out of the increase. Okay? Now, does that help us or not? Not. Thank you for answering that. It doesn't help us. Because here's what happens. When someone doesn't have primary care coverage, they may use the emergency room for their primary care coverage. In fact, 90% of the visits to the emergency room are not urgent visits. A lot of them may be primary care. And so you could go to a physician office for anywhere between $40 and $160 for a primary care visit, or you could go to the emergency room for $400 to $600 for a visit. Now, who's going to pay for that visit when someone comes with no insurance and no assets? It's going to end up you paying for it in increased premiums. About 5% of the people that go to the ER do get admitted. So there is some actual reason for the ER, but it's pretty much, I don't want to say that it's abused, because if someone doesn't have primary care coverage, they don't have any other choices. So, you know, even though the governors of all the states may opt out, I think Iowa is one of the states that actually is opting into that extra benefit, because in the first couple of years, the feds pay 90 to 100% of the increased people for eligibility. So, but eventually it'll be a cost to the state. Nebraska, I think, will probably opt out. That means that the rest of us that have commercial insurance will pay the difference. So I'm a nurse, and so I'm interested, what does my nursing organization say? And they approve and they support the ACA, and they see it as a way to make costs come down although we haven't covered that yet because it's not really in there, how are costs really going to be lowered. But the ANA does support the ACA. I think some of the things the ANA are thinking that as there are fewer and fewer physicians that are doing primary care, we'll start to see more nurse practitioners doing primary care. Studies show that nurse practitioners, their outcomes as measured by diabetes, blood glucose control, hypertension, weight loss, are about equal to their physician cohorts. When it comes to satisfaction, nurse practitioners usually score higher than physicians. The reason for that, maybe because most nurse practitioners are women, I don't know, but I think the reason for that really is that the nurse practitioner has more time. They don't have the same amount of demands, they don't always have the same caseload, and they spend more time per patient, even the men that are nurse practitioners. Okay, so Donald Berwick, he's former head of CMS. So what does he say about health care reform? Now that he's not the head of CMS anymore, it's kind of safe to say what he wants. 3 things. 1, health care reform, you need to improve the patient experience. 2, improve the health of populations. And 3, reduce the per capita cost of health care. Now, of those 3 things, what have we seen the ACA address so far? None of them. The ACA is really addressing insurance reform to make sure we have more coverage, and if we have more coverage, there's more access to health care. So the ACA is good, but it doesn't address everything that needs to be addressed, according to Donald Berwick and others. So health care reform is really health policy. And can health policy work? And what is health policy? Well, according to the World Health Organization, health policy really defines a vision for the future. It gains consensus. It gets all of us on the same page so we know what direction we're going in. And can health policy work? That's really the first question we want to ask and answer today is, what is health policy and can it work? So let's look at public health milestones. And public health milestones have been credited with improving lifespan by 25 years in the past century. Okay? So everybody who is 64 years old or younger, raise their hands. 64 years or younger. Oh, wait a minute. 54 years or younger. It's because the lifespan right now is 79, so subtract 25. If you can do the math, apparently I can't. Okay, so 54, because I saw some people I know are older than 54. That's why I knew I made a mistake. I'm not saying my wife's over there. Would never say that. Okay, so if you're 54 or younger, raise your hand. And I can't raise my hand. Okay. Everybody that's 54 or younger, keep your hands up. Everyone 54 or younger, if we didn't have those 25 extra years, you're still here. Okay? Everybody with their hand down, we're gone. Okay? We're deceased. Now, who thinks health policy can be good? Everybody that didn't have their hand up. I think we all want to raise our hands now. Healthcare policy does work, so let's take a look at what they are. And they're all things that we know about. Vaccinations, motor vehicle safety. Now remember, for a healthcare policy to work, it builds consensus. It gets us all on the same page, and it points us in a direction. So motor vehicle safety. Okay, I'm sorry I'm on camera for this because it's going to be ugly. But just to remind you of motor vehicle safety, buckle up for safety. Buckle up. Come on, you guys. Buckle up for safety. Okay, I don't know the rest of the words. Okay, now that worked. And so a lot of lives have been saved because we use seatbelts. Not just because they're required, because we still have to buckle them, but because we all got on the same page. We all know the little song. We all buckled up, and now we're safer for it. And again, those accidents is one of the leading causes of death. You know, if you look at the 5 leading causes of death, accidents is on there. And so this has actually helped those of us that didn't have our hands raised the first time, that now like public policy, you know, one of the reasons we're here. Safer workplaces, OSHA, Huge, really strides, and it really takes, for me, going to another country where they don't have OSHA rules to see how important it is in the workplace. So a lot of things like asbestos control, things that you're breathing, in hospitals, we want to be protected from bloodborne pathogens and things like that. So OSHA has been a big help. Control of infectious diseases, some of that's health policy, some of it's antibiotics, but a lot of the health policy for sanitation actually has more bang for its buck than even antibiotics. And there we have antibiotics on there. Coronary and heart disease, we've had a lot of education, so we see decreases there. And actually, I want to go over the cigarettes. I have a cigarette slide that hurts my lungs to even look at. And so we'll look at how health policy has helped with heart disease and stroke from smoking. Nutrition, healthier mothers and babies, family planning, fluoridation. There's my tobacco one, it's at the end. So these are the things that have helped increase the lifespan by 25 years, and all of us 54 and over are very happy about that. There's my slide. Okay, you got to shout out an answer here. When was it first known scientifically that cigarettes were bad for your health?
1960?
This will blow you away. 1938, this guy named Raymond Pearl showed that people that smoke cigarettes die sooner than people that don't in 1938. And whoever said 1960, that's good. 1964 is when the Surgeon General finally said cigarettes are in fact hazardous to your health. That was 64. But you see, cigarette consumption was still increasing then. And so with this public policy, we start to see this nice, I don't know where I have a cursor here. Oh, here we see this nice decline here where it is coming down. So we see, again, health policy working in this instance too. All right, so what do healthcare cost? What do we spend our money on? 31% hospital, 20% physician, 10% drugs. So 60% of the dollar right off the bat is tertiary care. Hospital, physician, and drugs. So it's high-level care, not so much things we do ourselves. Nursing homes, I'm a nursing home administrator, so I'm a little sensitive to how much people think we spend on that. It's less than 5% of the total budget. So can you guys read this? This is on healthcare expenditures. The doctor says, well, first we're going to run some tests to help pay off the machine. You know, I really appreciate you laughing. Usually when I do a presentation, I have to remind people this was a joke. So what are the public health initiatives that are going on right now, and what do we know about? That's why I took the courage to sing the Buckle Up song, because of things that happened in the past, we know about them. We know what the problem was, and we know what the solution was. Right now, it's pretty difficult to find out. Healthy People 2000, 2010, 2020. These are 10-year programs by the Department of Health and Human Resources to help to use scientific data to get the population to be more healthy. And does anyone know any of the initiatives for healthy people? One initiative from Healthy People. Yeah, it's hard. I know one because I looked one up. But there are 1,200 initiatives in 41 categories. Now, if we look at what the World Health Organization says on health policy, it's to get us some consensus, to get us on the same page, help us move forward, you know, as a group. Well, Healthy People, unfortunately, has too many indicators in too many areas for us to really get behind it and even have knowledge of what's going on. So it's not a successful policy. The HERO study is. The HERO study is a private organization, the Health Enhancement Research Organization, and they're specifically looking at wellness programs. How many people have a wellness program where they work? Okay, these are fabulous programs, and their studies show that they work. That there's really kind of 11 indicators. Those include things like smoking, weight, BMI, exercise, nutritional habits, that if we can actually help employees with those 11 indicators, we can reduce healthcare costs by 25%. Okay? So I haven't heard any percents from the ACA how healthcare costs will come down, but from the HERO study, your wellness program at work does work to decrease healthcare costs. Now, I know obesity is a problem, and we'll go over that a little bit as I move forward, but I only found one really push on identifying and decreasing obesity, and that's in Illinois, and that's where the Congress in Illinois charged the Health and Human Services there to develop a plan to identify risks and identify a plan to start to decrease the obesity problem in that state. Other than that, I haven't been able to really find anything. I am going to talk about the healthy people. Just give me a second and I'll get there. Okay, so what are the challenges right now for the 21st century? What direction do we need to go in? Well, when we look at Berwick and some of the things that are going on and some of the things that aren't going on, the two biggest challenges right now are effective means for wellness, number one, and a way to reduce the extraordinary cost of health care. So kind of question number one is, does health policy work? The answer is yes. Question number two, what do we need to be working on? That's what we want to identify next, to improve our health. What do we want to be working on to decrease healthcare costs? Those are the next two questions. So how are we going to do this? Well, there's this guy named Abdel Orman. He's an epidemiologist, and he comes up with this thing called an epidemiologic transition. So we're going to use this model to figure out what we need to focus on and how we need to get there. So we'll use epidemiologic transitions and we'll use demography. So the first transition occurred 10,000 YBP. Anybody know what YBP is? I didn't know. I had to look it up when I saw this. It's years before present. So it's kind of a secular look at time to see, BC, AC. Well, an easier way just to say, well, how long ago was that? So you don't have to do the math twice. So it's 10,000 years. We first transitioned from an agricultural society, from hunters and gatherers to an agricultural society. And so that really took care of a lot of famine and wars between tribes, because when you're hunters and gatherers, you have to fight for territory. So there were a lot of wars between tribes. So the leading causes of death were starvation or being killed battling for your territory. So then we moved from that into agriculture. Well, what happened when we moved into agriculture? The famine started to go away because we could grow our own food, right? Well, now that we're growing our own food, for the first time we're in one place. Sanitation becomes an issue. Plus, now there's cohabitation with animals. And so that's really the start of infectious disease. So the first transition is going from famine to infectious disease as the health problems. The second transition starts to take care of all that epidemic, pandemic, and takes care of the infectious diseases first and foremost by sanitation. So when they cleaned up sanitation and started cleaning up the urban environments, bubonic plague, all of those huge plagues start to go away. We didn't have antibiotics back then. What got rid of the plagues was not antibiotics, it was sanitation. Very simple. 20th century is characterized by more depression of infectious disease because of antibiotics. So at first, we see antibiotics working and decreasing infection and then starting to improve the health of populations. Well, what do we see now in this third transition? The third epidemiologic transition is what we're in right now. And we're seeing now that we're living longer, we've got these extra 25 years, well, what's happening? Chronic illnesses are going up on the rise. So we're seeing fewer infectious disease, more chronic disease. But not just more chronic disease, now we're starting to see our antibiotic arsenal not being as effective as it used to be. And here's some examples. One is we have what's called MRSA. Any healthcare people, MRSA, can tell me what's MRSA?
Methicillin-resistant Staph aureus.
Methicillin-resistant Staph aureus. Thank you, Nancy. So that means that the Staph aureus infection is resistant to its first-line antibiotic of methicillin. Okay, so now methicillin's not going to work. What's VRE? Vancomycin-resistant enterococcus. So it's another organism. Now vancomycin, which is your next level of antibiotic, isn't going to work. Okay, so now we have the third one, CRE. Anybody for CRE? Carbapenem-resistant enterococcus. So that means that the carbapenems, which are penicillin-based, if it's carbapenem-resistant, everything in that line of antibiotics is resistant to as well. Some of these bacteria are so smart they can trade DNA with each other. So if I'm not resistant and you are, I'll trade DNA with you so I can become resistant too. I don't know if they're highly intelligent, but they're mutate like crazy, and they can defend themselves so that they survive faster than we can come up with new antibiotics. So much so that, I have to look at my notes to see what her name is. The head of the World Health Organization, I think it's Margaret Chan. You'll have to Google it. But what Margaret Chan, the director of the World Health Organization, says is that hospitals now, rather than become a safe haven, have become a hotbed for resistant infections where, which are causing more deaths than, which are causing a lot of deaths. So she's saying we're starting to see the end of traditional medicine as we've known it for the last 50 years. It's gonna have to change again because our arsenal of antibiotics is no longer effective. What do you think of that? I think that's pretty scary. So this epidemiological model, in applying that can help us look at this disease scape and look at to see what are the things that are going to concern us, and now how are we going to deal with those things. And so we've seen right here what we've already talked about. Life expectancy, we've seen that go up over these epidemiological transitions down here. So early second, late second, early third. So as these transitions go along, we see life expectancy go up. We see infant mortality, meaning infant deaths, go down. And then we see infectious disease mortality in the early second, very high from infectious disease. And then we see that start to go down. And then we see chronic disease that are early start down and then go up and then come back down again. So we're going to start to see those chronic disease bounce up again in the fourth epidemiologic transition. So here's our trends for right now. Probably the biggest healthcare concern in the United States is obesity. And here we see somewhere in the around 1976 to 1980 period, it was going up, but you see it starts to skyrocket here. This is in the adult age 20 to 74 years old. What's kind of scary is that with children, you see the same curve of obesity. And when we're talking about obesity, we're talking about a BMI of body mass index of 30 or greater. So what's body mass index? What does it mean, and how do we figure it? Body mass index, and this tool actually, if you just Google BMI CDC, it'll give you a calculator. You put your height and weight in there, and it'll calculate your BMI in like 2 seconds, maybe 1 second. And so a BMI 18.5 and below is underweight, 18.5 to 24.9 is normal, 25 to 29.9 is overweight, 30 and above is obese. So I'm 5'10", give or take, and I weigh 160. So I thought, well, how do I get to be a BMI of 130? Well, I have to gain 50 pounds for a BMI of 130. And so
Not 130.
to get a BMI of 30, I have to gain 50 pounds. I would have to be up to 210. So I'd have to gain a little bit of weight to get into the BMI class. I just wanted to see what would that mean for me. Now, what I didn't do, but I'm curious about, because we have people now in the hospital that are 300, 400, 500 pounds. Those BMIs are way over 30, and we don't even have a category for that. The only category I know is just what's known as 100 pounds or over or more overweight. And so that's a category we're using to look at people. So is this all across the United States? Yes. That's the one thing I want to go back with. Remember Healthy People 2000, 2010. In 2000, healthy people said, we're going to decrease obesity below 15% of people with a BMI of 30 or more. We want that to be 15% or less of the population. And at that time, there were no states with a BMI of 25 or greater. By 2010, 39 states had a BMI of 20 or greater, and 12 states have a BMI of 30 or greater. So now let's take it to our present, and we find that in Mississippi, 31.6% of the population have a BMI over 30, and the lowest state is Colorado with 18.4. So we do have one state under 20, but that's the only state with less than 20% of the population with a BMI less than 30. Is this a global issue? No. Here's the United States over here with 30.6 overall percent of the population with a BMI over 30. And we go all the way down to Korea, Japan, Switzerland, where we're in the 3s. Switzerland's all the way up to 7. And that's percent of the population. But when you get to the more industrialized nations, Mexico, United Kingdom, United States, that's where you see the BMI start to come up. But nobody is in the class with the US as far as this being a problem. So here's our next question. What's the healthcare crisis of the current time? It's obesity. And what are the sequelae, or what are the diseases that go along with obesity? Well, the number one that goes along with obesity is diabetes. And diabetes, type 2 diabetes, is not something that's genetic and that you're born with. That's type 1. And type 1 we used to call insulin dependent. And type 2 we used to call non-insulin dependent, but those names don't work anymore because a lot of people with type 2 are insulin dependent. So type 1 really means that you are genetically born with the inability to produce enough insulin. Type 2 means that you have acquired diabetes through certain lifestyle decisions that you've made, weight being really number one on those, exercise, nutritional choices. Did I say exercise? Exercise being another one of those. So we see that people with type 2, more than half have a BMI over 30. Another 30% have a BMI between 25 and 30. So there we've got 85% of the issue is a BMI of at least 25% or greater. 44 million Americans are considered obese now. That's about 25%. 1 in 4. 17 million Americans have diabetes. The increase since 91 is when things really started to skyrocket. And so we want to look at why did that skyrocket in the last 20 years like that. Diabetes also has skyrocketed. 61% means it's more than doubled in the last, since 1991. So when we look at diabetics across cultural groups, racial groups, and across age groups, we see in all groups African American and Hispanic have greater propensity for diabetes than their Caucasian counterparts. A lot of that has to do with genetics, and a lot of that has to do with diet and lifestyle. So what does this cost us in dollars, and what does it cost us in health problems, both diabetes and obesity? Well, the conditions related to both diabetes and obesity are these: heart disease, stroke, kidney disease, impotence, vascular disease, nerve damage, blindness from diabetes eventually. All of these things are conditions related. Heart disease alone, what does that cost us? $450 billion a year for heart disease. Now, cancer is the number one cause of death. Heart disease is heart disease is the number one cause of death. Cancer is number 2. And you think cancer with all the chemotherapy and all the things, that would be really expensive. So those are 1 and 2, but really the 2 of those are about 50% of all causes of death. Heart disease is 25%, cancer is 23%. Cancer is only 190 billion, heart disease is 450 billion. One of the reasons for that is how much it costs for a bypass. We do 500,000 coronary bypasses a year, at $65,000 a piece. So that's how we get up to those huge dollars, is really coronary bypass. About 40 million, you know how McDonald's says how many served? We've had about 40 million coronary bypasses in our country so far. Here you kind of see how much dominant heart disease and cancer are compared to other causes of death. So you have 25% and 23% of those. Okay, so how did we get here in the last 10 and 20 years to have this huge problem, this growing problem with obesity? Well, portion size is one. 20 years ago, a burger was about 8 ounces, about 330 calories. It's almost double now. Now, the Wendy's, it's not Wendy's, I think it's Denny's double cheese, double burger. It's 1,400 calories. So that'll about do you for the day. Here's an interesting one. I like this. I ate pizza right before I came across this slide, and then I thought, oh, why did I do that? So 20 years ago, 500 calories. Today, 850. Okay, so let's do the difference is 350 calories. If you have pizza twice a month, twice a month, that it'll be an extra 2 pounds a year. That means in the next 20 years, 40 pounds. And all of us now, we have this increased lifestyle. Who wants to be here in 20 years? Me. So twice a month is 40 pounds. That's a lot of weight for pizza. So, huh? 2 pieces, yeah, I know. So, okay, that night I had pizza. Nancy and I went out with Don at this special place in Iowa City. I think I had 6 pieces, I'm sure. I could eat a whole pizza, I'm sure. Okay, some things to avoid that are really contributing to this increase in weight. Saturated fats. Okay, we know those are very high calorie. They also contribute to atherosclerosis, which contributes to heart disease, which contributes also to cancer. Trans fats, margarine. So we know that now we're starting to know that margarine and shortening are even worse than animal fats because those trans fats are artificially hydrogenated to make them solid at room temperature. So that artificial hydrogenation makes them, quote, sticky, so they cause extra atherosclerosis. Well, that stickiness was really a matter of the electrical charge because they're hydrogenated, and that electrical charge helps them stick to the side of the arteries where they can start to build plaque. So you really want to make sure you're not using the trans fats. And you want to read labels because guess what? Those trans fats are pretty much in everything, as is, where's my high fructose corn syrup? When you look at glucose, what really spikes your insulin up and your glucose up is the fructose part of the molecule, not so much the sucrose part of the molecule. So high fructose corn syrup is very inexpensive to make, but it's very bad for your it's a contributor to diabetes, and I have a slide on that I think coming up where I can explain how that works. Fried foods. That southeast part of the United States where we saw an increase in obesity is also called the stroke belt. About a 40% increase in mortality for stroke in that area. Much of that is attributed to fried foods. As good a food as fish is because it has omega-3, once you fry the fish, you destroy the omega-3, and then it's more unhealthy than healthy. So here's a note to self. When you've got olive oil, which we know, oh, it's so good for you, once you heat, why is it good for you? Because it's an antioxidant and it's an anti-inflammatory. Once you heat that olive oil, you oxidize it. So you really want to cook with coconut oil, with raw virgin coconut oil, which is very healthy for you. It's kind of a weight loss product, and it's very stable naturally. It's naturally hydrogenated. It got a bad rap in the 60s when they were looking at animal fats, and so coconut oil kind of disappeared. It's now come back. If you go to the health food store, they'll have raw virgin coconut oil. If it's yellow, don't buy it because it's been processed. Here's something interesting. So this is something that the FDA is not required to put in foods when this is added. It's transglutaminase, which is an enzyme. How do we make this? With pig blood, because pig with blood has platelets in it, which are sticky, and the platelets, when there's a cut, when we cut our finger, those platelets go to that area, and they help close the cut. And so they say, oh, this will work. So out of that pig's blood, or sometimes cow's blood, it's meat glue. And here you can see on what looks like sirloin, where it's fused together, where they glued the meat together. Okay? Now, this is something when you go to a restaurant and you think, a nice piece of meat. Maybe, maybe not. Could be scraps from wherever they got them. And they're glued together, and it's not required to disclose that there's meat glue in there. Now, these meats have been declared by the World Cancer Fund as to be too dangerous for human consumption. Well, now here's a clue. They're round, and I don't know of any animal that has these perfectly round meat things on them where you can slice. I always, if I could draw, I'd draw a cartoon of this animal that has these like round things, because they slice them and it seems, oh, this is good for you. Well, they guess if they use meat glue or not because it's scraps. They scrap together and then they press into this roll and then they slice it to make nice looking slices. But it's not so much the meat glue that's the problem here. It's the BHA, BHT, nitrates, all proven to be carcinogens. So they're all cancer causing. Plus these are high sodium, they're high fat. And so lunch meats should be on your no-fly zone. And they do cause obesity. And here's something I want you to know about. The USDA, okay, that's the establishment. So this isn't like a fringe group making this stuff up. The USDA studies all fruits and or the most popular fruits and vegetables. And what they do is they wash them and they test them for pesticides. And so they say, well, these have the most pesticides, these have the least pesticides. Now, why are pesticides not good? The FDA says they're good. Pesticides.
She said you don't get rid of them in your body.
Your body retains them.
Yes. Yeah.
Your fat molecules.
And your fat molecules, absolutely. Well, they're organophosphates. And the organophosphates are the exact same thing that the Germans used when they invented nerve gas in World War I. And so it's nerve gas. And how it works is it destroys the nervous system of the insects, of the pests that are going to eat the plant. So they put organophosphates, aka nerve gas, and then that residue gets into the plant itself that cannot be washed off. So the ones where it's the worst in the newest study, apples used to be number 4 on the list. In the latest study, apples are number 1 as most contaminated with organophosphates. And your body tries to protect you from them by hiding them in fat cells. Which makes me want to go on a tangent, but I'm not going to yet. Celery is number 2 because it's porous. Then you get into peppers, peaches, and then the leafy greens. The least pesticides. So if you're going to buy organic, apples number 1. Make sure you buy apples number 1.
If you're going to buy non-organic.
If you're going to buy organic, make sure if you're going to buy apples, make sure they're organic. When buying non-organic, asparagus, avocados, pineapple, corn, and onions are very low in this organophosphate. It doesn't mean they don't have any. It means they're at very low levels where they may be safe. But you're absolutely right is that the organophosphates don't go away. They're stored and stored and stored. And what happens with them is that they're nerve gas. Okay, so neurotoxic. They start to destroy the nervous system. So now when we have fibromyalgia and these autoimmune diseases, where do they come from? Well, this is one of the sources when we start to insult the nervous system and get an autoimmune disease. It comes from things like organophosphates and other BHA, BHT, nitrates, and the additives that are in our food supply. So what happens on a cellular level with the organophosphates is you get inflammation. And at a cellular level, this is what the inflammation looks like. But inflammation results in illness and most commonly pain. If I have a headache, my joints ache, my knees ache, a lot of the time that has to do with inflammation that can be dietary related. A food sensitivity is not an allergy. An allergy may be something full-blown that you're readily aware of. A food sensitivity is more subtle. Wheat, a lot of different things, milk, a lot of different things cause these sensitivities for all of us, even though we're not, quote, allergic. And those result in subtle inflammation, headaches, neck aches, grouchiness, tiredness, those kinds of things. So that inflammation is something that we want to pay attention to. So now we're up to sugar. Well, how does type 2 diabetes occur? Well, when we eat sugar or something, or any carbohydrate, the first thing that happens is the blood sugar goes up. And when the blood sugar goes up, insulin has to go up and take the excess blood sugar and take it to the liver and convert it to glycogen where it can store it for later. If there's too much glycogen, it stores it as fat. So there are things that are high glycemic, like sugar is 100 on the glycemic range. Where do you think white potatoes would be? 99. Where do you think a sweet potato is? 64. Where do you think honey is? About 64. So you've got things that are very high glycemic. Anything processed is going to be very high glycemic. So if I'm going to eat something high glycemic, I would rather eat chocolate with sugar in it, than a white potato. So I'm going to just get rid of potatoes because I'm not going to waste a bunch of glycemic out of control for a potato. I'm going to eat a sweet potato instead. So beans, legumes, very low glycemic. And the beauty of those low glycemic is they even out your blood pressure so it can stay between 80 and 100 all the time. So it's not spiking up and spiking up and spiking up. Because it's those spikes in blood sugar and insulin that start to cause prediabetes and diabetes. And we'll get to that in the next slide. There's a lag of glucose and insulin. When the glucose goes up, insulin goes up, but insulin stays up. It doesn't come down as readily. So that lag is going to start to cause damage at the cellular level. And what happens is, let me talk about, we'll go here. Now, we're pretty prehistoric, as far as physiologically. We haven't changed a lot in the last 1,000 years or so. And so we're really built to eat strawberries and fruits and vegetables. Well, one time I came to my office, and I'm sure I had a candy bar or something, and Dr. Balters, she's a nutritionist that used to work at Madonna, put a magnet on my door that had 1 M&M and 9 strawberries. I said, Sharon, what's with this? She said, well, Paul, the amount of sugar in 1 M&M is the same amount of sugar in 9 strawberries. So I go, huh? So, and then I think, well, how did I eat those M&Ms? Well, I took about 30 of them in my hand, and I opened my mouth as wide as I could, and I went, and I ate them all at once. Okay, is there any way I could eat 270 strawberries in one shot? So that's the difference physiologically. The body's saying, I eat strawberries, and so then we're eating M&Ms instead, and so we've got 200 times the sugar there at one time. That means we've got this huge spike in sugar, this huge spike in insulin to take that sugar because it's toxic at those high rates. So it's trying to get rid of that sugar out of the bloodstream. What happens at the cellular level is it becomes ineffective over time. All that sugar, all that simple carbohydrate is ineffectively handled by the insulin over time, and the cells then become what's called insulin resistant. They're going to push back and say, I'm not letting the glucose in. Okay? That's when starts the cycle. Because once the cells say, no, I'm done, it's toxic and I can't have any more sugar, then the sugar is malabsorbed because you have insulin, you have resistance to that glucose. And so what happens is you start to crave more sugar because you're missing the energy at the cellular level. You need glucose to turn ADP into ATP, which is what your energy source is. So you've got a problem there at the cellular level. Now what reverses that at the cellular level? What can we do to start to reverse that? Say I've already started, I've eaten sugar, and I'm not just talking about sugar, I'm talking about high glycemic. Processed food, white flour, white potatoes, white bread, sugar, all kind of in that simple carbohydrate category, which is going to cause that spike in insulin and blood sugar. I can reverse that with magnesium. Magnesium will start to help oxidize the sugar and get it back into the cellular level and also control the blood sugar level. What has magnesium in it? Spinach, kale, all those dark leafy green things are rich in magnesium. So why else would we want to eat spinach? Because it has folic acid. We know about folic acid because of prenatal. We know that if women lack folic acid, they end up with, there can be more propensity for birth defects. Well, folic acid also keeps blood pressure down, also keeps cancer down, also does a lot of things. Now remember, we had the slide on inflammation. How do we then decrease inflammation, which is measured by C-reactive protein or homocysteine in your physician lab? Actually, B6, B12, folic acid will decrease that homocysteine. And that's the American Heart Association and the American Diabetes Association also support those supplements to decrease your inflammatory response. So, okay, so I'm not going to eat sugar anymore. Okay, I'm gonna use artificial sweetener. I'm going to use aspartame, which is the most popular artificial sweetener that's in most pop. And I don't see any diet pops in the room, and I'm so thrilled not to see them. If you got one, hide it from me. Okay, now, if you Google aspartame, then you'll see sites that say, oh no, it has 0 calories in it, and it helps you lose weight, and it's healthy for you. Okay, so let's look at the science, because once I have a substance in there, I have to get rid of it. I have to metabolize it. So we're going to metabolize aspartame into a couple things. One, methanol. And methanol kind of shuts down your metabolism. But then when methanol gets detoxed, it detoxes into carbolic acid and formaldehyde. Okay? Formaldehyde? You do the math. I knew I'd get that in. So formaldehyde's good for dead tissue, but not so good for living tissue. But here's the real culprit in there, is that as we break down and get ready to excrete aspartame, we're going to break it down to this thing called phenylalanine. Now here's our real culprit, because it's a neurotransmitter that outcompetes serotonin and dopamine. And so it's going to sit on the receptor sites and trigger your body not to produce serotonin, not to produce dopamine. And one of the things that, who's our meditation person? Rachel. Rachel, nice presentation. One thing Rachel talked about is serotonin being an endorphin that helps you feel calm, helps you feel satisfied, helps you feel kind of chill. It's about 100 times more powerful than morphine. It's a very strong endorphin. It has great qualities. Well, the phenylalanine will take over. That means your feeling of fullness or satisfaction goes away because the phenylalanine has taken over those receptor sites, so you never feel full. So now I'm using aspartame where I think I'm losing weight, but it's creating cravings and preventing me from feeling like I've had enough, like I'm full. So actually they're finding that aspartame and those diet products like that, those artificial sugars, actually create more weight loss than they negate. Weight gain than they negate. Thanks. Good thing I have you here. Okay, so if aspartame is so bad for you, and meat glue isn't a listed ingredient, and how does that happen? Well, here's an interesting thing, and I haven't memorized these guys, so I'm going to read it. But I'm going to read you a list of people that have worked for Monsanto in their legal department, or worked in Monsanto's drug company, which is Cyril, or worked in Monsanto as part of the board of directors. And these are Ann Veneman, who's the head of the USDA, Robert Beachy, director of the USDA, Michael Freeman, the FDA commissioner, Arthur Hull Hayes, an FDA commissioner, Michael Cantor, U.S. Secretary of Commerce, Margaret Miller, deputy director of the FDA, Michael Taylor, FDA commissioner, Dennis DeConcini, U.S. Senator, Donald Rumsfeld, Department of Defense. He worked for Monsanto's pharmaceutical arm. Tommy Thompson, Secretary of Health, received $50,000 from Monsanto when he was running for governor in Wisconsin. So I have to say it again, you do the math. So the Monsanto's producing the chemicals. They actually produce most of the seeds that we use. They're the ones making aspartame. They're actually, there's too much of a marriage between the government, the USDA, the FDA, and former Monsanto employees. Sorry about this slide being so bad and hard to see. It's just because there's so many people in the FDA and the USDA that have worked for Monsanto, so the list is pretty long. But those are some of the main ones. Now, this is an activist poster that's interesting because they're trying to preserve real seeds because most of what Monsanto is producing are GMO, genetically modified seeds, so they can be resistant to bugs and actually resistant to organophosphates. So now I can coat the earth with organophosphates to kill the bugs, but the plants can survive. So they're Roundup ready. They can survive that kind of stuff. So the real seeds, they're trying to preserve them. If a farmer tries to clean the seeds and use his own seeds, typically they'll be sued by Monsanto because Monsanto has trademarked the seeds, so they own patents on them. So why am I really here? Because real healthcare reform really starts with you and how you deal with your own health. The only way really to have sustainable health, to decrease your healthcare cost, to improve your health, all those things Donald Berwick is talking about are through your own nutritional lifestyle choices. So things that Rachel's talking about with meditation, how to decrease stress. And I think you talked about stress, and stress is a huge epidemiological problem. I just want to get my statistic here. About 20% of employees say that they're stressed out. And because of that stress, those same employees have about 40% more healthcare costs than those that aren't stressed out. So how can we decrease healthcare costs by 40%? Well, meditation, relaxation, breathing exercises, yoga. Those kind of things are awfully helpful. Now, this isn't holistic. These are MDs from the conventional side of the equation. And when was Dean Ornish first discovered that heart disease was not only, you could not only stop its progression, but you could reverse it and get rid of it through nutrition? You know, that was 1990. And then Esalen around 2008 looked at the same thing. Now, Dean Ornish was very much into a plant-based diet, fruits, vegetables, whole grains, but not into any fats. No fish, no animal sources of protein, very strict that way. But his studies showed, yes, you did reverse and get rid of heart disease through nutrition. Now, Esselen's a little different because now we know about the good fats. Olive oil, omega-3s, almond oil, almonds, those kind of things. Avocados, those things which have omega-3 fats in them. So you want to have 30% of your diet with good fats, 0% or as little as possible with the animal fats, trans fats, margarine, those kind of things. So we talked about heart disease, also about diabetes. Well, both Whitaker and Bernard was really the first, talks about reversing diabetes through nutritional factors, going from insulin dependent to insulin free through nutritional choices. Now, those are things that we've been talking about. Long-burning carbohydrates, complex carbohydrates, beans, legumes, whole grains, fruits, vegetables. Those are the things that are helping people. So let's look at just some definitions here of health and wellness so we can see some of the difference. And when we think of health, we think of I'm either sick or I'm not sick. It's really a black and white kind of definition. And wellness is very different than that. Wellness is really has to do with your personal decisions on how, for the mind, body, spirit, social interactions, you can maximize wellness in each of those areas. And in fact, there's the dimensions of health and wellness where there's 6 dimensions that will be your emotional dimension, your spiritual dimension, physical dimension, occupational, social. Some of them even look at financial. There's a couple different models. So how do I maximize my wellness in each area? By paying attention to those, by assessing each one, and by making decisions that support wellness in each area. So here's my healthcare reform doctor. The patient says, "Doc, I'm not feeling well and I'm not sure why." And the doctor says, "I want you to meditate for 20 minutes twice a day, exercise for at least 30 minutes a day, avoid processed foods, eat plenty of organic fruits and vegetables, spend more time in nature, less time indoors, stop worrying about things you can't control, and ditch your TV. Come back in 3 weeks." So the holistic view of healthcare reform is really managing your wellness through yoga, through stress reduction, through nutrition, through exercise, and looking at all of those realms. Now, why is financial well-being part of well-being? Well, if you're worried about your finances and you're worried about making payments, then that's going to increase your stress. So you want to set yourself up where your spending matches your income so that you don't have those stresses of now I'm overspent or now I've used too much credit card. You know, I use my credit card for all purchases because I can pay it off at the end of the month and then I get cash back. Now, someone used my credit card in like Arkansas at a Walmart, you know, so my number got out there, so I didn't have it for a while and I had to use cash. Well, guess what? I bought a lot less when I had to use cash because I could see the money going out. So it's pretty insidious when you use a credit card. It's pretty easy to overspend. So determinants of health that we can talk about, I think number one is stress management, and Duke and Mayo Clinic and a lot of the major healthcare centers now are focusing on stress and stress reduction as part of a way to keep people healthy. People that are stressed out use more healthcare dollars by 40% than people that aren't, and about 1 out of 5 employees say that they're very highly stressed. So I really like the meditation exercise, but while we talk about stress, I want to do one little exercise because you can decrease stress at your desk or wherever you're working in seconds by making an intention to be more relaxed. And there's 2 pressure points that decrease anxiety, one right here, one right here. And so let's put our hands on, you can use 2 hands if you've got 2 hands. I have to do it with 1 hand. So put hands on these 2 pressure points and put gentle pressure. We're going to inhale, and as we exhale, we're going to sigh. Ah. And Rachel did the sigh too. The sigh is good because it tells you on a subconscious level everything's okay. So we'll do that one more time and note how we're feeling now. Big inhale. Exhale, squeeze, sigh. Ah, perfect. All right, thank you. So nutrition, exercise. There's a lot of different issues about exercise, but about 3 times a week is a minimum to get some cardiovascular and some weights. Who is it more important to lift weights, men or women? Women. Why is that? Because lifting weights puts stress on the muscles and the bones, and it helps push calcium back into the bones. When you're low in calcium, what's the supplement that you want to use? When you have osteoporosis, you want to do what? Increase calcium? No. So if your doctor is giving you calcium for osteoporosis, don't take it. What do you take for osteoporosis? Magnesium and vitamin C, because that's what puts...
D2, right? D3.
D3 is like the drug, that's like the supplement du jour.
Yeah.
But it's mostly magnesium and vitamin C that push it back into the bone. D3 will help. What's really going on in osteoporosis is that the person with osteoporosis is acidotic. Their diet is highly meat. Their diet is highly processed. There's not enough grains, vegetables, and alkaline foods. So things like apple cider vinegar and lemons, which you think are acidic on land, metabolize as an alkaline. That will make you less acidic and more alkaline and reverse osteoporosis. So it's really alkalinity that you want through fruits, vegetables, and once you pasteurize a fruit juice, then it metabolizes an acid. A fruit juice that's fresh squeezed metabolizes an alkaline, very healthy for you. I don't know if I have those in there or not. Okay, I just want to touch on this. The DASH diet, because it's now recommended by the USDA as an ideal eating plan for all Americans. It's what we've been talking about all morning. 10 servings of fruits and vegetables a day, organic whenever possible. Did I lose my mic? Fat-free, dairy, whole grains, fish, poultry, beans, seeds, nuts. Limit sodium to 1,500 milligrams. Now, what I like about this is, Dean Ornish was an MD. Whitaker is an MD. Bernard's an MD. This guy, not an MD, not a PhD. He was in the military. and he was at the end of his military career, and he had hypertension, and he wanted to be able to deal with this hypertension through nutrition. So he wrote a book called Dietary Approaches to Stop Hypertension, and now it becomes this #1 bestseller on the New York Times list, and it becomes endorsed by the USDA. So it's just a guy, and that's what I like about it, because all it takes is a normal, regular person to make decisions about their nutritional choices to change their health care for the better. Dash is actually the guy's name, Nick Dash, but his Dietary Approaches to Stop Hypertension. So I thought I'd show you that. So again, fruits and vegetables. I think he's eating a leafy green, magnesium. Magnesium helps control your blood sugar, helps control mood, decreases pain, along with folic acid, vitamin B6, vitamin B12, decreases your homocysteine, which decreases your inflammation. Now, it's pretty much, on the metabolic profile, we're looking at cholesterol and heart disease. Well, not so much. Cholesterol does end up risking you for atherosclerosis, but it isn't so much a marker of an impending heart attack or stroke. The markers for heart attack and stroke are really your C-reactive protein and your homocysteine. The way to get your homocysteine down is the green leafy vegetables, B6, B12, folic acid. Omega-3 and omega-6, we know about those because the research shows that it decreases atherosclerosis. It'll make me more heart healthy. Now, what we really like about omega-3 is they're anti-inflammatory. So all those little aches and pains, rather than take an NSAID, a Tylenol, an aspirin, an ibuprofen, we take fish oil to decrease inflammation naturally. The other thing important about fish oil is your nerves, actually just like an electric wire that has the insulation around it, your nerves have insulation called a myelin sheath. That myelin sheath is made of omega-3 and omega-6. Peanut butter is omega-6 and omega-9. Almond butter is omega-3. So keep that in mind. You want to really boost up your omega-3s. And omega-6 and omega-9 become inflammatory when you get more than your minimum amount required. And most of our diet's omega-6 and 9. So you really want to get the omega-3s from flax oil, almond oil, olive oil, salmon, and those kind of fatty fishes. Whole grains. Let me give you this image. Think of like just your digestive system, and I'm going to eat a white grain, white bread. And when I think of that, I think of my gut as this glass tube, and I'm going to stuff toilet paper down there and then pour some water to swallow that and try and digest that. And what's going to happen when I eat that white grain, that toilet paper? It's going to be sticky, and it's going to slow things down. And as the transit to the gut slows, toxins start to proliferate. So I want to put sand down that glass tube, whole grains, so I'm cleaning it and sweeping it out with every meal I eat. So that's why I'm going to do what these guys do and do whole grains. But I'm not going to stop eating. And in fact, plenty of water. How much water?
Lots of water.
Minimum is 8 glasses a day. And easy to say, not easy to do. It's hard to get that much water. So a lot of us now carry our little water bottles and make sure that we fill them up about 4 times and make sure we get a lot of water. There's a video called Food Matters, and they suggest drinking as much water, 2 or 3 glasses of water when you first get up to start to flush your system out and get yourself going. And that gives you a start on the day to get your water and a little reminder how much water to drink. Now, for those of us drinking coffee all day, not such a good idea because it has a diuretic effect, so you might be actually getting less fluid than you think because you'll be losing some of your fluid that you've got. Now, we've talked about obesity and diabetes, so we want to make sure of this. You're such a kind audience. I have to tell people, like, they're not laughing at this. I think this guy's hilarious. Okay, so what are our nutritional requirements? The basic metabolic rate, if we sit and do nothing, it's about 1,500 calories. So that means I can sit and do nothing. I can watch TV all day and eat one of those Denny's double cheeseburgers. Anything else over then I'm going to start to gain. But you want about 15% only in protein, about 30% fat, and about 55% carbohydrate. It doesn't mean you can binge on carbs. We're talking about brown rice. We're talking about whole grains, beans, legumes, those slow-burning carbohydrates, broccoli, the leafy greens, those kind of things. And when we talk about fats, we're talking about coconut oil, olive oil, avocados, and those fatty fishes. Here's interesting. This is another study, the calorie study. It's a comprehensive assessment on long-term effects of energy. Here's what they found, and they're studying both humans and animals. When they decrease the caloric intake of animals by 25 to 30%, they're doubling the lifespan of that animal. Decrease calories by 25%, doubles lifespan. Decrease calories in humans, memory goes up. Another thing they're finding in the stroke belt in the South, 40% more mortality from stroke, more obesity, more diabetes. Guess what else? More dementia, more Alzheimer's disease. They're seeing a correlation between high calorie intake, bad fats, lack of exercise, and Alzheimer's disease. Couple things that I think are interesting things to do. We talked about inflammation. In Germany, where they've had national medicine for decades, they do a lot of herbal and supplements as well as medicines. In the United States, we take Tylenol, aspirin, well, not so much aspirin because of Rye syndrome, but Tylenol, ibuprofen, those kind of things for inflammation. In Germany, the number one thing they take for inflammation is bromelain. And bromelain is an enzyme that's made from the stem of a papaya. Now, a proteolytic enzyme is an enzyme that typically, when eaten with food, breaks down protein. But a proteolytic enzyme eaten on an empty stomach becomes a metabolic enhancer and decreases inflammation. So a metabolic enzyme is very powerful at decreasing inflammation. I had a headache and took 3 of them this morning, and I don't have a headache now, so it worked pretty good. Here's another enzyme. So bromelain in Germany is their number one supplement that they use, an anti-inflammatory. Now, this comes from Japan. It's serrapeptase. Now, this little silkworm in its intestine has a bacteria called serrata, and it spits it out when it wants to get out of its cocoon, and that enzyme eats the fiber in the cocoon so the little worm, so he can get out and then become a butterfly or a moth or whatever he is next. So here's how that works on humans. We take serrapeptase. Yes, it has anti-inflammation, but also starts to get rid of all that plaque in the arteries and starts to clean us out, all the pipes out on the inside. So serrapeptase to get the arteries cleaned out, bromelain to keep us anti-inflammatory, 2 really good supplements. We hear about D3, vitamin C, vitamin E. These we don't hear about so much, but I think you'd find them very beneficial. I think this is hopefully towards the end because I'm out of time. But most bacteria like an acid condition and an absence of oxygen. They're anaerobics, gram-negative rods. Cancer is an anaerobe. But if you introduce cancer and those bacteria to high oxygen and to alkalinity, a pH approximating 8, they not only can't multiply, they die. They can't survive that way. So our pH is between 7.35 and 7.45. It's a very narrow range. But when we eat foods like processed meats, animal proteins, pasteurized juices, we're going to be more alkaline. We're going to be more acid. Thank you. How would I do without you? We're going to be more acidic. When we're eating avocados, green leafy vegetables, apple cider vinegar, it's going to push us towards more alkaline and it's going to be more healthy. It's really hard. You actually have to get a list to see what's alkaline and what's acid because it's not so much what it is on land, it's how it metabolizes into an alkaline ash or an acidic ash. Oh, here's my tricks for maintaining a normal weight. And I got some of them from my daughter. Number 1, never skip breakfast. Once you eat breakfast, you start to get your basic metabolic rate going. That's most of your calories. You need about 2,400 calories. 15 of those are just your BMR. If you can kick your BMR up, you can burn more calories. So breakfast is really important. Servings of fruits and veggies. But here's the real good ones. Drink a glass of water before you want something sweet. Make yourself drink that water, then you're not going to eat so many cookies or crackers or whatever. And here's the one that the guys at the gym and I do. We brush our teeth and before we're going to watch TV or do anything. And And we don't want to mess things up after we brush our teeth, like eat a snack. And if you eat a snack, you have to brush your teeth again. And pretty soon, you're just going to not want to eat more snacks. And it makes you think not to eat a snack anymore. The hardest time is we watch TV a lot, we're sedentary, and then we start to snack. So for a lot of us, it's that TV time. So if you can conquer the TV time, brush your teeth, drink more fluids, watch less TV, talk to your mate more, then that'll help you lose weight. An apple a day or an apple before snacking. Anytime in the middle of the day you get hungry, eat an apple, eat some almonds and raisins as a mixture so that you don't get super hungry when mealtime comes. Exercise, manage stress, focus on your breathing. Now you notice when a baby breathes, you don't see his chest move at all. You see that little tummy going up and down. That's because he's using his diaphragm to breathe. And so when we do our meditation, when we are doing our breathing, we want to focus on not holding our gut in anymore, but relaxing our stomach out and using our stomach to really pull air in and out. I think Rachel went over these. Okay, why is rest important? Your hormones get balanced during sleep. There's a hormone called ghrelin that stimulates appetite, and leptin decreases appetite. If you don't get enough sleep, your ghrelin goes up, your leptin goes down. So you've got no appetite suppressor and lots of appetite increaser. So this is one of the science behind when they say sleep and obesity are related. If you get a proper amount of sleep, and Rachel, I think you said most people are sleep deprived, 8 hours is a proper amount of sleep. Now, I do an hour meditation, so I count that as my hour. So if I get 7 hours plus my hour meditation, I figure I've got my 8 covered. But you want to get as close to 8 as you can. Meaningful work is part of your well-being. You know, if you're going to spend most of your waking hours at work, you should make it count and be engaged. And the more engaged you are in your job and the more you can make it meaningful, your well-being will go up, according to Gallup, by about 40%. So you want to be sharp when you're at work and have some meaning then. Laughter, you talked about laughter meditation. Well, when I had my illness, I was down for the count for a while. I had brain surgery from a brain tumor. There's Nancy and my son Luke coping by laughing. And I'm sure I was the joke, but... but laughing, it says Bob Newhart, our medical expert, is very good for you. So in summary, the real healthcare reform is what we do ourselves, is to make good choices, understand what's good for us, understand what's not, and make our choices based on that. I think you called it the awakened life, is to consciously make your choices, be kind to yourself, and be kind to others. And thank you for coming.